A1C is 5.7, so at the cusp of pre-diabetes. Essentially patient wants to lose weight. We start this patient on tirzepatide. This is March, after it's been officially available. What I want to show here is the body composition analysis, and that's another important part to monitor. In body composition analysis, you're seeing the skeletal muscle mass at 32.2. The overall score is 48, which is poor. As this patient follows up in June 25, gradually it's been stepped up to 10 milligram tirzepatide. A1C came down from 5.7 to 5.3. Substantial fat loss. The fat has gone down significantly. What we have to watch is the muscle mass. Fortunately for this patient, the muscle mass has not reduced much. It was 30, I'll go back. It was 32.2 and now it is 31.7. So 0.5 kg muscle loss, which is fine. So that's important aspect to monitor. Similarly, in another case scenario where we have used in a younger individual, 17-year-old, 101.4 kg, initially started on metformin, vildagliptin, but wanted to lose weight. He of course became an adult. Oral semaglutide was initiated for his sugars and for the weight loss benefit. What do you see here? 107.8 kg, a skeletal muscle mass of 30.6. Over a period of time, a year later, his weight is down to 96.1 on oral semaglutide. 11 kgs this boy has lost. A1C is down to 5.6. Fortunately, the skeletal muscle mass, which was 30.6, has improved to 32.5. So when you use these drugs, protein supplementation and resistance training for the muscle is extremely important, and that's the message I want to leave all of you with, is that we need to learn newer monitoring aspects when we use these drugs. The future of CGM and incretin therapy is extremely important. So wherever possible, when you are adapting to new drugs, use CGMs to monitor. It helps you, it helps the patient see better. With that, these are of course where the lot of references were drawn from, those couple of papers. And let me wish all of you happy Raksha Bandhan, and I welcome you to the DRS conference 2 weeks from now in Mumbai. Would be happy to see any of you joining us there. Thank you, organizers, once again. Thank you.
Respected organizers and the respected chairs and the stalwarts of the dais. So my topic is a very interesting topic. We keep treating patients and we keep focusing on lipids, LDL, 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 but we forget that there is a huge ecosystem beyond LDL. What is that? I would like to play this video. Maybe you can just have a look at this. So that is what is important. We forget that Titanic plays a role everywhere in our life. Titanic makes Shah Rukh Khan say kaka Kiran. Titanic makes our hospitals suffer. Our patients die because we do not see the ice under the sea. So this is the same thing, residual risk after LDL correction. We do not see the huge burden which lies under the sea and which causes a lot of problem. This is the hook in India. 68% myocardial patients have LDL below 100. 68% have LDL below 100. Residual risk is 52%. Because of that, the economic burden is 2.17 lakhs. And there is a 3 times higher risk in the Indian patients compared to Caucasian patients. Question is, we are Indians, we are treating Indians. Why are we missing this huge lipid burden that we are not aware of? Something very unique for India. Very, very typical Indian pattern. High triglycerides, 42% prevalence, low HDL cholesterol, 72% Indians have less than 40. A small LDL is 35% higher than Caucasians. We get diseases early, we get myocardial infarctions much earlier. We get most of the infarcts which LDL is below 70. And we get a premature coronary artery disease with 12% prevalence. And we are treating our patients with statin as a monotherapy. We keep treating it and we look beyond that. So I've gone through a lot of literature. For this presentation, I went through umpteen amount of presentation, and we realized over there that there is a lot of work already existing since 2008, and a lot of research has been talking about a lot of issues which are present in a lipid ecosystem beyond LDL. In spite of the best of benefits offered by statin therapy across various populations, the mortality levels have not come down. Ischemic heart disease still today remains the #1 killer across the entire planet, in spite of the fact that they are on 40 milligram and 80 milligrams of atorvastatin. A huge chunk of diabetics, we know that diabetes is a big risk factor. 14 leading statin trials absolutely renowned leading trials, when a meta-analysis was done, they were shocked to see that the mortality and morbidity ratio was very high in spite of the HbA1c being under control. So what are we missing here? We are missing a huge bus because we are very happy to treat our diabetics and non-diabetics with good dose of statins. So there are a lot of other risk factors. You're looking at low HDL cholesterol. This is a risk factor for dyslipidemia. The problem is it is an independent risk factor. The point to be noted is it is not just a risk factor. It does not matter what is your LDL cholesterol. Non-HDL cholesterol is an independent risk factor. This is a huge study from the Framingham study. Let's see something very important over here. Look at patient 1 with LDL cholesterol of 100 and the HDL cholesterol of 65. The risk is 0.4. Patient 2, LDL cholesterol 100, HDL cholesterol 45, risk is 0.6. Important, pay attention to patient 3 and 4. LDL cholesterol in both, one is 100, HDL cholesterol is 25, the risk is 1.2. Whereas when the LDL cholesterol is 220 and the HDL cholesterol is 45, the risk is yet 1.2. Moral of the story is, though your LDL cholesterol is under control, the risk remains very high because the HDL cholesterol is not under control. So though we know that VLDL cholesterol and triglyceride-rich lipoproteins are able to enter the arterial wall, look at these 5 quintiles and that tells you very clearly that there is a huge amount of passenger traffic and business that we are missing because we are focusing on very limited traffic. So look at the chylomicron remnants, look at the cholesterol remnants, look at the triglycerides, look at the VLDL, look at all these things. When patients' triglycerides were less than 150, they were independent recurrent cardiac coronary events, that showed very clearly that triglycerides play again an important role. So non-HDL cholesterol, triglycerides, chylomicron remnants, all of them play a very important individual role. Moral of the story is you need to treat them separately and not as a family. If you look at this data very clearly, if you look at the LDL cholesterol which is less than 130, you look at the death rate and the cardiovascular risk, and you look at the non-HDL, when you combine it with more than 190 with an LDL below 130, the risk is as much as when non-HDL was less than 160 but LDL was more than 160. So moral of the story is LDL cholesterol management does not really benefit your patient in any way. So understand this concept of non-HDL cholesterol. It is now being recognized as an independent risk factor and it's a separate ecosystem of lipid management which has got nothing to do with statin. This is the blueprint of the Janam Patri where everything is happening. The entire ecosystem of lipidology is lying here. You're seeing the liver over here, very busy slide. Multiple lipid remnants are there. The entire therapeutics of lipid management, whether it is statin or what, is all over here. I'll move out. You can take a snapshot of this. This illustrates where different drugs are working. A huge pharmacology arsenal is present. If we just go through this file, you have omega-3 fibrates, PCKS9 inhibitors, antisense, anti-inflammatory molecules, ETC molecule, PAPA, alpha and gamma agonists. And if you see the LDL is reduced more by PCKS9 inhibitors to the tune of 60%. But we are thinking of statins. If you look at the ezetimibe, the LDL is reduced by 24%. These are drugs that we do not give importance to. Look at the MACE. The MACE is decreased by omega-3 fatty acids. MACE is decreased by, again, PCSK9 inhibitors. And if you look at the anti-inflammatory drugs like colchicine, it reduces MACE maximum. Have you thought of prescribing these drugs to our patients? Have we paid importance to these drugs? What is available in India? Those drugs are not available in India. At least PCKS9 is probably not frequently prescribed. But if you look at the statins, fibrates, the agonists, the nicotinic acid, bile salts equivalents, you look at the dosages, you look at the cost, not so expensive. But if you look at the figure on the right, the LDL reduction, triglyceride reductions, MACE reduction, phenomenal and huge with drugs which are not statins. So let me just encapsulate you certain drugs. Saroglitazar, one of the best drugs in the market, produced in India by Zydus, an Indian molecule, a very cheap molecule, fantastic drug, dual inhibitor, works very well in atherogenic dyslipidemia and glycemic control, 45 to 55% TG reduction within 12 weeks, improves non-HDL and apoprotein B, reduces the residual cardiovascular risk, fantastic drug for NALFLD and MFLD. Glycemic control is a boost, is an add-on. How much? 0.7 to 1 grams of HbA1c, which is fantastic, which is unheard of. Indian molecules are very cheap and easily available. The only reason it is not popular is the Western world has not given it credence because FDI has not approved it. There is not large CV outcome data. There is some amount of alpha gamma inhibitor risk like edema feet and osteoporosis, etc. Because of lack of global acceptance, we also blindly follow the West and we don't use it. So long-term uncertainty, NASH approval not officially done on paper, little interaction with statins, and narrow evidence base as of today is preventing us from writing it, though it is a fantastic molecule. Look at the bempedoic acid. This works a little upstream of HMG coenzyme A reductase inhibitor. It's a prodrug which is activated in the liver, no activation in the skeletal muscle, so none of the myopathies of statins is there. So if your patient is having a myopathy, you can replace it safely or you can give it as an add-on. The reduction is 38%, which is huge. Clear outcome 2023, fantastic reduction, very good for intolerance, once a day, safe in kidney disease and fabulous for residual risk. Problems? LDL reduction has got little limitations, hyperuricemia and gout, little costly, but in the elderly people, there is a little risk of tendon rupture. Look at the PCKS9 inhibitors, evolocumab, alirocumab, and inclisiran. Very good drugs, fantastic drugs in the labs, not yet very much popular in the doctor's prescription in his chamber. And if you look at some of the newer kids on the block, you can see some fantastic drugs like ANG TPL3 inhibitors, the evinacumab and the solbinirisan, some new molecules, and there are some chai molecules which are coming out through the artificial intelligence pipeline. This is an area which is very close to me. It's not yet got clinical approval. The trials are on the way, but the initial results are absolutely promising. If you look at olezarsen, which is an ApoC3 inhibitor, it's an antisense oligonucleotide. It reduces it to the tune of 60%, unheard of, 60%. And if you look at this drug, which is an ANGPLT inhibitor, it reduces your LDL gene producing LDL permanently. One shot, you're permanently out of LDL increase. It's a permanent cure. So now like we are looking at GLP agonists as a permanent cure for obesity, we're looking at some of these drugs which could be a permanent cure for dyslipidemia. So I've been giving you a lot of 2030 and 2040 telescopic views. Let me come back to 2025, and this is what your current guideline, CSI 2024 guidelines and the LI guidelines. Very clear, you need to start fibrates, you need to look at non-HDL, you need to look at pancreatitis, you need to look at triglycerides below 500 and above 500, you need to assess, give lifestyle measurement, but do not forget to add fibrates and omega-3 fatty acids beyond statins, beyond ezetimibe. Do not forget to do that even if your LDL is under control with 70. Now these are position statements and guidelines by our own forefathers, by our own people. Very important that we don't forget it. So this is the 3P framework. Predict dyslipidemia and infarctions in your patient, prevent it from happening, and give precision medicine. Personalize your prescription to that patient. So it's not that one code suits all. You can't just take a statin, an ezetimibe, a fibrate or a niacin and push it on all your patients. No. You need to work out the pathophysiology and give real personalized care. So let me just walk you through what is precision medicine and beyond LDL in 5 or 6 cases. Patient A, 48-year-old executive, type 2 diabetes mellitus, post angioplasty, Rosuva 40, LDL 58, TG 285, LDL 32. You predict the lipid assessment, as you can see over here with apoprotein of 125. You put him on a fenofibrate 160, which will prevent further increments in triglycerides as per the field and accord trials, and you can personalize it by giving it over 12 months, and you can see that the HDL has boosted up to 40. No CV events, fantastic drug. Below the two references. Second case, 55-year-old teacher in Chennai, postmenopausal, hypertensive, LDL 65, HDL 28. You can predict the HDL quality assessment. The only drug you consider here is saroglitazar 4 mg once a day. The benefits are HDL came down from 28, boosted up from 28 to 38, TG reduced by 35%, absolutely no cardiac events. Third case, 42-year-old professional from Bangalore or maybe Coimbatore, lipid A assessment 85, screening to affected siblings, residual risks of 2.5-fold, Indian prevalence 25% have got this elevated lipoprotein A that we hardly check. We actually check because our patients come from ThyroCare and other labs getting a 50 or 60 analysis done, and then we pick up our eyes and we see, yes, something like that has happened. We just put this patient on 1 gram of nicotinic acid. I'm sorry, it's not easy to tolerate nicotinic acid, so I'm giving this as an example, and 1 gram twice a day is a huge dose. The practical approach is titrate to 3 gram if it is possible, and add your Rosuva and ezetimibe, add an aspirin, get his hypertension under control, fabulous control of lipoprotein A. So here I'm managing only lipoprotein A with nicotinic acid. 60-year-old businessman from Delhi, stable coronary artery disease, LDL 62, high resolution CRP 5.8, interleukin 6 elevated. What I need here is an anti